Yeah, thanks again for having me here, especially on an evening. So we did one on Monday about general endodontic diagnosis, and tonight we're going to go over a little bit more about sort of retreatments, some retreatment strategies, and things I kind of consider when approaching a case that's potentially been referred for a retreatment, or when you're considering doing a retreatment. Just a few sort of stage by stage things you can start to think, and just helps you kind of guide you about whether you think it's the right thing to do, and some sort of little tips. Tonight's ones, I've got a lot of cases just to sort of show you through it, because I think that's sometimes a bit easier, certainly for discussion. And again, if you've got any questions, you just pop them in the chat, and then we'll try and get through them at the end. If we're running a bit short time, then I might skip a few of the cases at the end, but just any questions, just let me know. So I'll just share my screen now. No, I can't. Yeah, so endodontic decision making and indications for retreatment. When are we considering this? So again, I wanted to kind of just keep it quite sort of straightforward and simple, and mainly keep it case-based. But we're going to talk through the factors that were responsible for endodontic failure. So assessing why a tooth is failing, why a root filling is failing, then leading that to consider the prognosis and the planning of when we're considering redoing the treatment. Some of the benefits we have now with CBCT, and helping this sort of diagnostically with that, but then also some of that planning as well, because it will often make us a lot sort of more streamlined in how we're going to plan our cases and appointments. A little bit on calcified canal systems. I think that's a lot of times why some root treatments look like they've not been successful, or why obturations may well be short, and a little bit on that. And then say case by case, and a bit about management of difficult cases. And I say I'll talk through some of the ways I manage these things. They may not always be the right for every case, and different people might have different ways, but some of the things I find quite useful in managing these cases. So with retreatments, it's the same principles of endodontics as for re-endodontics. We're trying to preserve and stabilize these teeth. We're trying to prevent infection and reinfection, or reinfection if you want. And then we're also, got to ensure that we can rebuild the function and the aesthetics of these teeth as well, because there's no point, doing the retreatment if it can't be restored at the end. And again, we approach that in the same sort of way. It's, doing our access cavity, trying to preserve whatever tooth structure that we've got there. Bear in mind, it's previously had an access cavity, so if we're taking out any previous core materials, we want to be quite mindful of that. The shaping protocol that we're going to go through, so we're not completely obliterating all the dentine that's in the tooth. And irrigations, dressings, often quite similar, but we sometimes have additional choices that we may want to use for retreatments. And then again, what obturation options we may have as well. Whether it's a retreatment that's failed and it's got more apical resorption, and we're going to have to consider using MTA or other sort of materials if you've got wider canals, apices now. And also a little bit about surgical endodontics and how to do that. And again, the coronal restoration that we want to do as well, because it may be that some of these things have failed because of the actual restorative issue. So I say that I always try and kind of take it back to biology and standards and say, well, okay, if someone's done this endodontic treatment the first time, they've tried to do their best and do it well, but it's not worked, and is it just a time thing, or has there been something that's led this to not go to plan in the first instance? So is it a case that there's just some additional canal complexity? Has it been a really difficult tooth to treat, and therefore the person who's tried first time has not been able to completely debride that entire system? Is that because there's severe curvatures? Is there potentially sclerosis in these areas? Have there been any missed canals? I know certainly a lot of the things I get referred tend to be upper molars, where we are finding MB2 canals in the majority of cases, and certainly that's one of the key reasons why you may well see failing upper molar, because there's an MB2. Or again, with the canal complexity, has it just led to poor chemical irrigation in those areas? Have they just not been able to shape it in a sufficient way to get enough irrigant down into that space? So that's kind of the canal side of it. Has that prevented the first person doing it really well? And therefore, can I improve on that to try and improve the situation? So as well as notifying it, it's like, well, can we do anything about it? The reason sometimes these will fail is because we have separated instruments and it potentially been used maybe inappropriately. Has there been a canal blockage or a ledge formation and someone's been doing the treatment initially, and is that what's caused perhaps a short obturation? Has there been a perforation, not just coronally, people looking for there, but has there been a strip perforation in the way they've managed the canal curvature? Has it been underfilled? Has it been overfilled? See, underfill, there may be a reason why overfill, and that will affect on how we then approach it to manage that. Has there been any corrosion of the root canal filling materials? Is it just something that's been there for a very long time, and then it's just over time thing? The no previous use of rubber dams is always a tricky one for you to know about unless you know that who's referred it through to you, or you can ask the sort of questions once it's been referred. Can you check back in the notes from whoever saw it and say, have they used this? Because again, it gives us an indication of what irrigants may or may not have been used and if it's been contaminated during that procedure. And then restorative errors and periodontal issues, because often endodontically treated teeth will fail because not because of the root canal issue, but because of another issue, which is the restorative or the perio. Has it just got a poor restoration? Has the restoration been lost? Has it got caries around it? Is it leaking? Has this tooth not had full cuspal coverage? So is the risk of any cracks or fractures that have led a new way for pathogens and microbiomes to get back into that space? Or is the tooth completely fractured? And if it's completely fractured, then again, we've got a bigger concern, and actually restoratively we might not be able to do anything about that. And it's trying to sort of assess these things radiographically and clinically to see, okay, why is this tooth potentially failing? And if I can find out why, what can I potentially correct to then maintain and get the function back. So again, same sort of headings like canal complexity. So if we've noticed that they may have missed some, can we find it all? And using something like cone beam will really help with a lot of that. But also knowing your anatomy of teeth as well, and knowing which teeth are most likely to have premolars with multiple canals, certainly lower incisors with multiple canals. That's often the one that commonly gets missed. Actually, lower incisors are probably one of the more tricky teeth to cut, and there often is a missed lingual canal. Can we appreciate that? Can we take parallax images? Managing sclerosis, if true sclerosis is an issue, is that the reason why someone's not potentially been able to get to the apex? Because the importance in reaching the apex from all the studies that we see is being within that 1 to 2 millimeters of the apex, not beyond it, and not short, to make sure we've cleaned it well. And we've got patency, so we've got no blockages there. And also, is there any element of resorption internally, externally, and is that going to affect how we're going to obturate and restore these cases? Then looking at the iatrogenic things that we mentioned. So is there a separated instrument? And if so, do we think we can remove it? Do we need to remove that? Where is it in the tooth? Canal blockages and ledges. Sometimes you can see it. It's quite a you may see there's a canal beyond where an obturation has got to, and you think, well, how's the person not got there? And it may well be that they've blocked something, or whether that's with restorative material or by overworking files and created like a ledge that they then can't get around. So can we get around them? And when will you know you can get around them? And that's really only when you actually start treating that. And a part of the consent process is telling the patients beforehand, so that, if you go in there and you can't get past it, they've been aware that may be one of the consequences of trying this treatment. Perforations, we see them quite, infrequently, thankfully, but they are relatively common. And if it's in the floor of the chamber, is that an easier area to repair? If it's coming out the side of the tooth anteriorly, where the tooth may have been angled, and someone's got their angulations wrong when they're accessing, so finding out where that perforation is, and that can sometimes lead back to cone beam, and we may be able to see that a bit more and help guide our accessing these issues. Managing an overfill as opposed to an underfill. So if it's an obturation that's gone beyond the apex, what are we going to be able to do to get that material out of there, it's GP and it's a loose fitting point, you might be able to get the whole thing out. But if it's, you know, well packed and there's a lot of sealer beyond there, is that when we then maybe need to consider, is it retrograding? You know, when I say retrograding, we mean apical surgery approach. Is that going to be what's required to actually clean out that sort of overfill and manage the issue that way? And then the restorative concerns, which is the same as you probably would consider it the first time. Can we, you know, restore this tooth anyway? Is it as well as redoing this? And the patient may say, oh, I want to save my tooth, I want to save my tooth. But actually, you know, is it the right thing to do? Can we definitely restore it? And how long can you predictably restore it for? Or do we, you know, want to service that patients better by saying, actually, you may well want to consider the alternative, which could be a dental implant, if it's going to give you a better life expectancy, etc. When I say, do we need to do an initial clinical investigation, that means actually doing that first part of treatment to remove potentially crowns, restorations, before we can then actually tell the patient confidently, yeah, I think we can do this, or actually, no, there's a crack or there's a fracture running through the tooth that we're just not going to be able to save. And, you know, you need to charge appropriately for that time and the cost of the materials that you're using, but you need to make sure the patient is kind of bought into the fact that until I start, I don't necessarily know, and how we're going to manage that. Because, yeah, you want to know the other implants and the cost lifespan of the tooth. So root fractures and cracks as well, they're certainly one of the ones you really got to be looking out for when it comes to retreatments, because we're seeing them, you know, a lot, and certainly in initial treatments, I'm seeing a lot of cracks, which has led to pulpitis. But again, cracks and fractures that are causing root-filled teeth, especially if they've not been restored with a full coverage restoration, like a crown or an onlay. These are, you know, one of the key reasons why these teeth fail. I mentioned sort of some of the choices we have with restorative materials we may want to be using. And then I say the periodontal factors. Is the person motivated to improve those perio issues? If a tooth failed because of a, you know, periodontal issue, can we get them to, you know, motivated to improve that? So we're going to overall get a good result. So I'm going to just go through a few cases just to kind of go through those points in my sort of the step-by-step way, and then this is how I kind of approach a case. So this is a gentleman who's referred to having symptoms from the upper left 5. Tooth's got a crown on it. Crown's been there for a long time, as has the root filling, so we're talking 15-20 years, but we can see there's an apical radiolucency, and there's something in the canal there, slightly radio opaque, but it's not really towards the end of the tooth, and we think, well, what exactly is going on in this area? So again, is the fact that it's underprepared, it looks like it's short of the apex, so have they left some bacteria down there? Has there been a missed canal? Have they obstructed one here? It looks like there's a significant root and thickness, and there's a chance there's probably 2 roots in this area. The obturation that we see on a radiograph gives us an indication that potentially it's been underprepared and insufficient irrigation to get down to the bottom there. So that sort of leads us to why we think that this tooth may be failing, and also starts to show us opportunities that we can then improve on these things, to then tell the patient confidently, yeah, I think if I can improve on this, this, and this, we're going to be able to maintain and keep this tooth for a while longer. So in this case, I did opt to remove the crown. Sometimes on some occasions later, I will go through crowns initially, but that's only if the crown's been there relatively recently, within the last few years, and I'm confident the crown looks very good. If it's been there for a long period of time, and I know we're going to need to replace it, then 9 times out of 10, I'll take it off initially, so I can actually investigate and check there's no cracks or anything else. So here we've isolated. Often I'll do multiple teeth isolation, so that I can then do the restorative part and then lead straight into the endodontic part. But I know some people favour just single tooth isolation. Again, there's no right or wrong. So section the crown off, got an amalgam core that's in there. So a few wedges to kind of help keep things in place. Taking out the amalgam, we start to see there is some GP in that space. It looks a bit sort of leaking around there, starting to kind of be a bit discoloured. But actually there is a GP point in one of those canals, and it pulls out in quite a single piece, which is always the best way to retreat things. If you can get those GP points out whole, brilliant. It's going to save you a lot of time and effort. And then here we can see we've got 2 canals. We've cleaned it all up nicely. We've spent a good bit of time with our irrigants cleaning. I've got apical patency. I've got to length, because once that GP's out of the way, It's then almost just treating it like a routine case. We can then take our master point radiographs, ensure that we've got now down to within 1 to 2 millimeters. So in this case, there wasn't any ledges, there wasn't any blockages. It's just the fact that I think when it was done probably with a bit of speed, and the GP hasn't been, placed well enough and irrigated well enough. And now I can kind of confidently say to this person, yeah, we've cleaned this all, we've sealed it, we've got a nice composite core in there, and just refine the margins. I'll put a temporary crown on that, and then send it back to a referring dentist and say that should be okay. You can look and plan your definitive restoration there. But it's again just going through that sort of process of how we approach these things. And if you can get these things GP taken out whole, it's brilliant. So some of the factors that may affect the outcomes of re-endodontic treatment, because I think there are some things you're also looking for, as well as how well it's been done outside the tooth. And one of those things is there a periapical radiolucency? So there's a big lesion on there, then there's obviously a host response to bacteria. Some say it's not always the bigger the lesion you got, the lower the chance, but if there's a bigger radiolucency, there's this then a disease process going on there. The bacterial status of the canal, which sure, taking a sample and looking at doing a culture of it, you're not going to know, but you need to know that you can then actually get in there and clean it all out again. And as I say, just reiterating this point, it's like, can we improve what's there? Can we disinfect that entire space? And then again, how much residual dentine have we got left? Because we want to make sure that we're doing that and can remove files. So this is some of the GP that you can take out of canals, and this kind of gives me a rough indication of what that bacterial status of the canal might be. Sometimes you take GP out and it looks almost pristine, it looks clean, but sometimes you take it out and it's got this horrible like anaerobic bacteria, all this kind of black sludge and muck on it, which shows you really there's a lot of nasty bugs and bacteria in there and all their byproducts, and that's what's causing potential swelling of these lesions to really occur. And if you're going in and it's this dirty inside there, that you're going to really have to spend a good bit of time cleaning, irrigating it, and often considering dressings. A lot of normal sort of routine orthograde first time treatments we'll tend to do them in a single visit if we can. Retreatments, that's probably 75% of the time we'll do them over 2 visits, and especially if there's any sort of sinus or swelling, then I do tend to like to do them in 2 visits. Now some people will do them in single visit, and I do in some cases, but if I see all these sort of black sludge and everything on his teeth, often I will dress these cases for a while, because I want to see a sign that we're getting some healing. If there's a sinus or a big lesion or big swelling, but yeah, actually look at what you're taking out of these canals as well, because they'll give you a rough idea of exactly what's going on there. See, a lot of these images, you'll see they've got headstrong files pulling out the GP point, which is one really useful way of getting GP point out whole. If it looks relatively loose fitting and you can get some K files and then some headstrong files either side of a GP point and then braid them and twist them together, as you then pull it, often the whole GP point will pop up and pop out, which is brilliant because it saves you having to use loads of solvents, which I tend to stay away from if I can, or it saves if you're using things like reciprocate files. It sometimes creates a lot of GP mess that you then have to clean out, so you can get them out whole. It's brilliant. And again, so why do we need to reach that apical part of the tooth? So often in the retreatment case we see it's because there's a short obturation, and that's one thing. Well, actually, is the canal beyond that? Is it completely sclerosed? Is it the fact that it's a ledge or a blockage? Because all the evidence I have to say is we want to be filling within that final 1 to 2 millimeters of the radiographic apex, but we know using our apex locator and the radiographic apex and the actual apical foramen and where the constriction finishes can be a little bit dissimilar. So again, I still would rely heavily on my apex locator in a retreatment case and try and ensure that you can get in patency. Because again, the reason we kind of want to maintain patency is to make sure that we've cleaned out and debrided all that space at the end of the tooth, and we haven't got a blockage and residing bacteria that are still going to be in the end of the tooth there and causing that inflammatory response with the tissues around it. So again, another upper premolar, again going through the same sort of thing. why has it failed initially? Is the restoration of the tooth possibly leaking a little bit? Why have they been able to only get the obturation up to so far? Is that because there's two canals that join or split at that point? Is it because the rotary file or whatever files people have been using have created a ledge, so they've gone in with a straight file without a pre-curve on it, and has it just created a ledge that then they're not be able to pass, and has it created a blockage? I say, is it two canals that are joining into one? Is it the restoration? But I know if I can take the GP out and then pre-curving a file a little bit, just so that you put a slight curvature on the end of it, just to then try and have a feel and bypass that ledge that's there, can get a file past it, take a working length radiograph of the file. Again, I don't always take these, but if I want to check that I think I'm round a bend or around a curve, sometimes I will, just to make sure I feel a bit more confident than using either a rotary or reciprocating file. And at this point, we're then just treating it as a regular root treatment again. So we're just going to clean and shape that master point radiograph, and then obturate, and then a whole new composite core in the tooth. I've left it quite low in the occlusion just so there's no risk. I think it had quite thin cusps, and then sent it back to the referring dentist so they can then place a crown over that tooth there as well. So the key benefit I think I have in sort of endodontists, or people have a special interest in endodontics like myself, is the magnification and microscope. And loops are certainly a great start. And if you've got loops with a light, I know a lot of the loops companies now do 4, 5, 6, 7 times, but a microscope is, for some of these things, really invaluable, because often if you can see these things and you can see where GP may go, or certainly when you come to files, if you can see it, you can appreciate it a bit better, and often you can treat it a lot more easily. So certainly using something like a microscope or loops will improve the sort of overall ability to treat these types of more cases. And I say I'm lucky enough to work in 2 practices where both I use a Zeiss microscope, which is fantastic. And when things like calcified canals, microscopes are definitely a big plus, because you can zoom in 20, 30 times if you need to. Not that I often work at that, but you can definitely see a bit more, because calcified canals are often the reason you'll see not blockages, but short obturations. So there's always a few things to keep in mind when you do see a calcified canal. If you go in and you just can't find where the canal entrance is, and people start then searching with high speeds, and that's when you start to get in a bit of trouble. So as I mentioned before, trying to get patency, one thing that we will see on a radiograph, it may see that the canal is completely calcified or sclerosed, but then you'll see an apical area and a lesion on the tooth, which actually shows us that there's definitely got to be a canal there, because if there's a portal of exit for these bacteria to get to, that's what's causing the body's response to it. So if there's a lesion, then there's definitely going to be a portal of exit. So the canal is definitely present. Complete calcification, and certainly the apical part, is very, very rare. So it might happen a little bit higher up, and that's why sometimes you do have to search a little bit with certain types of burrs, etc. But the actual bit, as I say, near the apex and that final third is incredibly rare, and that's why I say there's slightly, if you see a lesion, you will see there's a portal of exit, and it's just trying to maintain and getting to that. And that's when you've got to use the right equipment. So you're not using high-speed burrs, you're using things like fine ultrasonic tips, using what are called gooseneck burrs, so long-shanked, small round head burrs, and you're just trying to carefully feel your way down there. And looking under a microscope, you'll often see this little sort of white dot in the centre of the dentine, and it's you start to be able to read the colour changes in dentine from when it transitions from the side wall dentine, where it's quite nice creamy and white, to the sort of floor dentine, where it's kind of a greener, darker, blacker colour. And often you can zoom in and create with this, you'll see this little sort of white dot that you're trying to sort of follow, and that's the sort of the entrance to that canal. The body obviously loves symmetry generally, and with the exception of some upper molars, the canal is always going to be centered within the root. So if you've got a central and you've got a root that's round, the canal is always going to be the middle part of that as you go down. So it's trying to appreciate where the root is in relation to the crown and within the bone and the tooth tip at all. But you know, if you try and stay centered within that root space, that's where the canal is going to be. So that's why sometimes you can, they are calcified in the first third, middle third, but you know it's there because you've just got to take your time and carefully use Longshank Berks just to stay in that middle proportion. Keep stopping, keep checking, and always looking for that main canal within that central portion of the tooth. And again, if you're, say, treating the lower molar tooth as well, you know, if you draw a midline straight through the tooth, if the mesiolingual canal is sort of 3 or 4 millimeters off to the lingual side, well then the buccal side, the buccal is also going to be the same distance from that midline. So teeth generally, with the exception of some of molars, have, you know, a certain level of symmetry and laws, and there's some good papers on that you can find quite easily that help you to try and read floor anatomy and tooth anatomy, and knowing, you know, where the canals are, that the fact that the entrance to the canal is always going to be in the transition between, for a molar, between where the wall and the pulp floor meet. The canals are always going to be in those corner areas of it. But say magnification light's the biggest help. And as well as some ultrasonic tips, there are some certain hand files that are also really useful for doing this. So what I tend to use is these gooseneck burrs and ultrasonic tips, long shanked ultrasonic tips. Some of them are diamond cutting, some of them aren't, some of them are fluted. The real benefit with these, especially using a microscope or loops, is that the actual ultrasonic head or the drill head is far away from the actual working active part of the tip, so you can actually see a lot more. But these gooseneck burrs are really good. They come in the same size as your rosehead burrs, 2, 4, 6, 8, etc. Micro openers is essentially a file on a stick, so it's a hand file it on a small stick, but you can also get little holders that you can put normal files in, or you can just use tweezers and hold a file. Again, it's just trying to get your hand out of the way so you can see in a nice clear front surface reflecting mirror and not have your hands or a handpiece in the way, so you can see a little bit more. C plus files, they're from Dentsply, and there's another one called C pilot files, which are from VDW. The C plus files have an active cutting tip, so again, they're useful if you're just trying to sort of pick away that initial sort of calcific entrance to a canal, because they've got a slightly wider taper, so a little bit stiffer as well. And again, the C pilot files, they've got a slightly wider tapers, they're a little bit stiffer to try and get these canal inches and just try and work your way down calcified canals, or if you think curvatures you want to kind of get around. Then more with these choice, the second two, the last two, the retreatment files and irrigants, that's more when we're thinking what are we using to remove previous root filling material. So some good perk if you can't get out whole and it's quite sort of densely packed. Retreatment files are sometimes quite useful to take that out. And also reciprocating files, I find Reciproc is really good at just kind of churning out old GP that's in place and hopefully trying to avoid too much use of solvents. But again, that's why I've said irrigant choice, because I know solvents are quite commonly used in retreatments, be it chloroform, eucalyptus oil, or other sort of orange solvent oils. The reason I try and stay away from them is because if I can, so there are cases where you do have to use them, it's because it just creates a bit of a sludge of sort of dissolved GP that you then need to remove, and then as well as removing the sort of the GP and the solvent, you've then got to get all this sludge off the walls as well. But there are cases where you have to use them, but if you can do it without, sometimes I think it's better in the long run, because you're then having less sort of GP mush to clean out of there as well. Other options to take out is using things like heat as well. So if you use like one vertical down packer tips, they're sometimes quite useful at cleaning out the sort of first part of the GP, because if you heat it and place it in there, often it'll back out the canal, and you can take it out that way, which is quite good. Or using just dry ultrasonic tips, really fine ones, and just heating that into the canal, and that heat will melt the GP, and sometimes you can remove it that way, and that's less of a mess to sort of clean up than some of the solvents are. Just a little bit on sort of file separation, if you're considering doing that with a retreatment, and this sort of table is taken from a combination of a few things, but generally with a file, you need to be able to see it to remove it generally. unless of course you can bypass it. So depending on where it is in the canal, or if you think you can get past it, if I feel I can just get bypass it and get past a file or a broken small part file, then I'll just continue shaping carefully just to make sure I don't separate another file, and feeling how tight it is in the canal. But then I'll create my glide path potentially with hang files, and then use something like a reciprocate file. And sometimes it'll bring it out, but sometimes it may stay in place. But if that file's there and you've bypassed it and you've cleaned the apex, then I've no real qualms about leaving it if I think it's going to be too destructive to take it out. Then if you can't get past it, this is when you really need to think, well, where is the file within the tooth? If it's in the apical third and it's a tall curved route, straight, and you can't see it, then often you may have to leave it. Certainly from an orthograde approach, surgically, if it's in the apical third, you may be able to remove it surgically and do things that way. But if it's in the apical third and it's a tall curve and you can't see it, then often you're not going to be able to get it out. If it's in the mid or the coronal third and you can get straight line access to it, and by straight line access I mean, essentially getting down there with a modified gaze glidden or some other ultrasonic tips to actually see it, then yes, we do want to try and attempt to remove it, but only if we can get straight line access and we can see it through the microscope. And then we want to try and attempt to remove it. And if you want to see videos about people removing files, you should look at Yoshi Teruchi, because he's like a wizard when it comes to removing files. So I won't try and go through that, because he's got a good few sort of lectures, webinars and videos even on YouTube that you can see of him removing files. But then again, if we can't get straight lines, can't see it, then again we may need to leave it and consent the patient appropriately that we may not be able to get that out. But yeah, the other thing you want to consider when you are taking it out is why it might have fractured in the first place. So let's say, a lot of people know this, but there's two main ways why a tooth may fracture, a file may fracture, and that's cyclic fatigue. So if you're just bending a stainless steel file over and over and over again and you've overused it, eventually the material will weaken and it will break at that point. Or has it been torsional failure? And this is where we see it potentially more so with hand-driven files now, where the file is binding in a few areas, so it can't rotate further down, but it is still being turned higher up, and then it breaks above that point where it's bound, and that's where it sort of binds lower down and shears higher up, and then often that's as it goes around a curvature, if the bottom part is binding, then the bit higher up will shear off. And so sometimes you want to be looking at these things when you think, oh, there's a file there, not just can I see it, but also I wonder how that fractured and got there in the first place. Because the first tooth we see, the lateral incisor on the left, this is almost like an entire pro-taper file that's fractured in there. But we would hope that it's not bound along its entire length, but this is certainly one that's fractured by torsional failure. It's bound in somewhere along its length. The handpiece is still continued driving, as the lower part hasn't, and it's just untwisted and eventually broken and come off. So I'd imagine it's probably somewhere in the sort of middle to apical part of the tooth where that's happened. I didn't actually end up getting to treat this one because the guy, his symptoms settled and he just didn't come back. But that one, you'd want to try and get that out. You can't really leave it, and the chance of bypassing will be quite tricky. But there, you're going to probably have to try and open the top part a little bit more and get some ultrasonic tips on that, and just see if you can get it moving and see if you can kind of unwind it a little bit. The next one in the middle of the screen is actually a K file, size 15K, and this is one that's just broken because of cyclic fatigue. I think it's just, well, there's a fault in the file, but it's just twisted and it snapped. That one we know, we're going to be quite confident we can get that one out, or even bypass it, because we can see canal beyond that. And I think if we just loosen up where it is bound a little bit, just with some ultrasonics, that one pinged out quite easily. The one on the top right on my screen, look at it again. It's just cyclic fatigue. It's a small part of a K file that's probably been overworked in some of the other teeth, and it's just bound a little bit, and that's the final thing that as they've pulled it, it's come away. So again, we know that one should come out relatively easily. It's just involves sort of loosening up a little bit around the top. But then the final one in the bottom right, where you can see that's again a K file that's gone round a bend. This is probably a combination of cyclic fatigue and torsional, so it's probably been overworked, but then it's bound in somewhere and they've kept twisting at the top, and it's just got itself wedged, and eventually the cyclic fatigue gives up and it's come away. But that one, you're not going to ever be able to remove that by going through the tooth. It's trying to straighten out, it's going in towards the curve. That's one where you really got to kind of master your surgical skills and see if you can resect, obturate the rest of the tooth normally, and then raise a flap and remove the file, and probably the apical's up part of the root with that one. Again, the patient in that case declined treatment because they didn't want to go all through that. But these are things you've got to be able to discuss and explain, and let the patient know. There's no point just doing it on and spending all this time and effort if the patient isn't kind of bought into the fact of what's involved. Yeah, a little bit just about preventing file fracture. It's the usual things we're taught is crown down, not overusing files. Certainly in the UK, we use rotary reciprocating instruments. We don't sort of reuse them on multiple patients, which certainly would cut down on the cyclic fatigue version side of it. But you always want to just make sure you keep checking and looking at your files, make sure they're not unwinding, make sure they're not untwisting anywhere, and just sort of reduce the chance of happening. Because sometimes you think, I'll just use it once more, and that's when it breaks, and then you hate yourself. But yeah, it's generally sticking to the protocols of how to use these files and not overusing them, just being careful with them and knowing just to go, right, that one's unwinding, let's get rid of it now before it breaks. Because file fracture can often happen again while you're retreating, especially if you've got blockages and you're trying to get around stuff. Often, if you think there's a ledge, you're using multiple sort of C+ or K files or trying to get around things, keep checking them, because the last thing you want to do is make matters worse by having a little ledge or blockage and then separating one of your instruments because you're trying to push too hard or you're trying to overwork it a little bit. But yeah, I think we're going into a few more cases now, and just again, it's the same sort of thing each time. I'm really wanting to assess, why has this failed, what can we change, and can we then restore at the end. So here it's a short obturation. When I saw the patient, they'd lost the restoration in the coronal part of the tooth, so the GP's been exposed for quite a while. Got the start of a bit of radiolucency at the apex. So has this tooth been failing for a while, or is it just because it's been reinfected without the restoration there? Why is the obturation short? Has it just not been irrigated particularly well in the first instance? And so I'm thinking, well, yeah, hopefully if I can get that GP out, get a good restoration afterwards, give it a good clean, then we've got a good chance that this one's gonna work well. So restoration out, or temporary out, all the caries that was there cleared. We start to see the GP that's in the space. I think at this initial visit I did a build up as well, just to make sure that I was happy that I could definitely restore the tooth afterwards. So there's no point in going through all your root treatment side of it and then find out that you can't isolate it to place a restoration. And then here we can see there's a composite wall distally that were built up, and that's just some calcium hydroxide dressing in the tooth. I think that was all we did at the first visit. And then the second visit, we've managed to clean. I think there are 2 canals there. I think that's what some of the GP we've removed is in that top one. And then we've placed a composite core, and knowing the patient's then going to go to the referring dentist again to get a definitive crown, because it definitely is going to need a crown. The restoration's not going to last too well in that case, and we don't want the patient being back in the same place having lost the restoration and leaving it. This case, we're actually looking at the lower 4. I know the lower 6 doesn't look ideal either. Again, short obturation, but there's no actual lesion on the mesials there. It's the 4 that we're looking at. And here again, we start thinking it's got a short obturation, but it looks like I can see some canal beyond that. So hopefully we can get past it. I'm thinking, is there a second root there? Because I can see a slightly different shape to the root on the mesial side in the middle area. The restoration of the top part of the tooth doesn't look particularly great, so is that leaking a little bit as well? That's it, yeah. So here's the post-op where I've been able to clean out, get beyond it, get a good obturation, get it cleaned up. So you can see the extent of the radiolucency, and then I think this is about 6 months later, before we planned an onlay for the tooth, we can actually see the size of the radiolucency is healing there now. There was 2 canals in the tooth, but the patient's happy, symptom-free, and we've got signs that we've got healing there, so now we can protect that tooth a little bit more. All premolars today. But yeah, another lower 4. This one, it's a bit of a strange one because you can see there's a really wide canal space and then it suddenly disappears. So is this potentially where somebody's tried to access and search for canals and not been able to find them? Or has it just always been quite wide, and then is it a tooth that actually then splits off and goes into different areas? So we were thinking, we've got missed anatomy. Is there any canal beyond that space? Is the restoration failing, which I think it is. I don't think it's great. And also we're looking at where the actual periapical lesion is on the tooth. And here we can see it's more on the mesial side of the tooth as opposed to just around the apex, which kind of gives an indication that there might be a lateral canal or an exit on that mesial side of the tooth that we know we want to try and get into. Here with Rob, I'm getting readings on my apex case saying that, you know, I'm at the apex, or we've certainly got some patency, but it looks on a radiograph that it's a little bit short. But if we take a parallax view from a slightly different angle, we can see that actually there is two canals that do have a low split, and one of them really kind of goes off towards the mesial side of the tooth. And that's where we can kind of now appreciate a little bit more that radiolucency is in the mesial part of the root, because actually that's where one of the canal or the portals of exit is. And when we see this radiograph, we don't actually see too much of a lesion right at the very radiographic apex. So it makes me feel a little bit more, happy that the portal of exit is more on that mesial side of the tooth. And upper premolar now. So this gentleman, for some reason, had a temporary crown in place for about 2 years, I think, because someone had tried to do a root filling but hadn't been able to find. I'd found one canal and wasn't too sure, so left a temporary on it, and then it had started to niggle a little bit for the patient. So it looks like, you know, they've got one canal right in the middle of the tooth. So you think, well, I wonder why they were struggling in this tooth. And that's when you start thinking, actually, if I take an image from a slightly different angle before I start this retreatment, or in some cases you could take a cone beam now, we can get a sense that there's two roots in this. Well, there's three roots in this case. We've got definitely one that's been found, but actually take an image from a different angle. This is a 3-rooted molar. And then if you go back and look at the first image, you can start to sort of see it a little bit more where the roots are. Sorry, I don't have a pointer I can use with a zoom. But you can start to see a little bit more. And I think certainly when you look on the master cone radiograph, we can really see that this is why the people have struggled initially to find what they thought was the buccal canals, actually, because there's 2 buccal canals and they do sort of split and go off. And then you've got that obturated, a better core, and then a new temporary crown. And then you can sort of be a bit more confident and tell the patient that, yeah, you can get a permanent crown placed on this tooth now, where you can restore that tooth so you can hopefully forget about that one again. Okay, so, yeah, sorry, that's the wrong X-ray. Again, lower molar. Now, again, same sort of thing. It's got a crown with not too great margins on it. It's been done in the last couple of years, but so we explained to the patient that that's not ideal. We need to look at that. But then also we've got some short obturation in the mesial canals. Looks like an initial quite severe curvature in the distal canal, but we've definitely got some missed anatomy. So is there a reason why they're not been able to obturate the 2 mesial canals? Sometimes, often in lower molars, you'll find that the mesiobuccal mesiolingual join. Sometimes I think, well, actually, is that what's happening here? Is it the fact that these 2 GP points are bumping up against each other, or they create a ledge? Distally, is it because there's a really sort of severe curvature? You can see that there's quite a bulbosity to the root, and that's really where the radiolucency is on that distal part of it. So I'm already looking at these things saying, well, can I improve on all these? And this is where I had to kind of discuss with the patient first. Until I get in there, I don't know exactly how, if I can get beyond where there's potentially ledges in these mesial canals, because it looks pretty, you know, doesn't look like there's a big canal space that's there. I'm also saying there might be a crack in this tooth. Ideally, we want to take the crown off first and do that. But then by taking the crown off, if you're temporizing these things for a while, it's a little less stable. So actually in this case, we've decided that we're going to go through the crown initially, but to see if I could, you know, what we could do, if we could find the space in there, and then ultimately if we can retreat the tooth, we'll then replace the crown. Our referring dentist will replace the crown quite soon after, with that caveat that actually with the microscope I can still check and make sure that I'm happy there's no root fractures or cracks running through the tooth as well. Because if you make a reasonable access through the crown, you can still sort of check those to a degree. Not quite as well as I would say as taking the crown off completely. And this one, was a bit of a brute of a tooth. It took me I think at least 2 or 3 visits, 3 visits. But once I know I've got they actually have thermophil carriers in it as well, and they were wedged in, and they were really tricky to get out. Thermophils, I don't know if everyone watching whatever, thermophil is like a carrier-based obturation. So it's the old style one, which is a plastic carrier with GP around it that you heat in a little oven, and then you're meant to just passively put into the canal. But these have just been wedged in. So as well as getting the GP out, you've got to get these wedged in plastic carriers along the whole length. And it's similar to taking a file out, you've got to try and loosen it. But because it's plastic, it vibrates. You can't send ultrasonics through it like you can with a file. So it's more of a pain to get out. But here, I mean, post-op looks really nice. We've got two distal canals, separate apices. You can see the curving around there. I think I've just used hand files to get around that and spent a lot of time cleaning and irrigating. You can see a little bit of the H+ sealer just going out through some of the lateral anatomy in the apex there. And again, the mesials are 2 separate roots, so then it's not joining and bumping together. It's just the fact that they've not shaped it and cleaned it well. So again, I know I've improved on the cleaning, the shaping, got to within that 1 to 2 millimeters of the apex, got all the old material out, placed a good core, and so now he's going to go back and see his referring dentist quite soon afterwards to get the restoration replaced, because there probably is a little bit of caries distally, and that'll need managed as well. But I'm still happy that the tooth is restorable. We've checked what we can. Yeah, I say a few more cases. Actually, I might just zip through a few of these because we've got a little bit on cone beams as well. Yeah, similar sort of thing. Upper molars, I mentioned at the start. This is often the ones where we see that there's an MB2 missed more often than not, especially when it looks like it's a little bit of a short obturation, big lesion, failing restoration. We know there's a few things there that we can definitely improve on. And these are ones where arguably you could take a cone beam first as well, which might help give you even more information. So when actually treating this tooth, you're going to go, you're going to make more efficient use of your time as you're there. But yeah, 2 separate mesial canals. Maybe I can do the joint separate. A little bit of sealer going out to the end of the tooth, but I think that's because I had a big lesion and then a replaced restoration. I say I'll get on to just conscious I don't want to keep everyone too late on a Wednesday evening. But yeah, pain, infection. This is where I've used the braiding technique to get the old GP out and try and take it out whole rather than using any sort of solvents. And you took it and pull it out. And this is where it looks really sort of dirty. You want to make sure that we're cleaning this well, spending a lot of time cleaning it, dressing it, and then I think I had a slightly wider apices where there's been a degree of external resorption, but then just make sure you're planning your obturation as well. And I think we left those, didn't completely seal the back of the teeth because he wanted to do some internal whitening because the teeth are darkened and discoloured over time. So that's why those obturations look a little bit low. Okay. This is one where perio is the issue for the patient, but we're really trying. She's not suitable for implants, doesn't want a denture. She wants to save this tooth for as long as possible. Really looking at the obturation, it looks like it's got a dozen GP points in, probably from cold lateral back in the day, but it's got a really wide sort of canal spacing and opening. So is it the fact that it's been up and irrigated? Is it obturation, or is it a failing restoration? Is it perio, or is it a combination of everything? I'm going to have access through the crown because this is really kind of a salvaging it for quite a while, and we've dressed it and then actually obturated this one with MTA. You see it's really wide. To be able to do that with GP, you're going to, as the person before, not just pack in loads of additional points or try and get a bit of a plug and then one vertical. But I say using MTA is brilliant in these cases, and then a little bit of GP over the back of it. And patients aware this is really just a matter of time. We're just trying to buy a couple more years really. I think this was one that, again, poor restoration. Can we improve on that? Yes. I think it was referred from a patient who was a dentist who could see that the person who'd done it in their practice previously hadn't used a rubber dam, hadn't cleaned it with any sodium hypochlorite. So again, I now know, because the obturation looks not too bad. It's within 1 to 2 millimeters of the root apex. So these ones, I think, well, actually, is it just the fact that it's not been cleaned out well enough first time? And these are some of the more, sometimes the trickier ones to actually redo. It's easy when you've got a really loose GP point and you can take it out whole, but the ones where they've actually been obturated quite well, but just haven't been irrigated very well, the ones that sometimes take you a little bit more time and care to get the old GP taken out. I think this was a pre-op that was sent. So this was before another general dentist had attempted the root filling. You just see it's got a big leak in restoration. But once we've got all the old GP out, again, I think I used something like Reciproc, and I don't think I used any solvents. We can get it all out, take the bits out. Using headstrong files are really useful as well at getting the GP out. A little bit of a core build-up, and I've had to use a bit of liquid. I think it was quite a low tooth once I took the crown off in this case, made sure there's no cracks. Obturated, and then sort of more of a composite core. And I think we left it like that actually, rather than putting a temporary crown on, just to make sure it also showed signs of healing. And then, now this is where we see, this lady had been referred because she's having ongoing issues with the lower 7. So the obturation doesn't look too bad, maybe a little bit short. Restoration looks pretty good. So the previous note said that it had been done under upper downward sodium hypochlorite, so I think okay. Irrigation's possibly quite good, but you can sort of see on the radiograph that the bone loss is more on the mesial side of it. So this is when we start thinking potentially more cracks and root fractures, and certainly as part of your assessment you want to be using a BPE probe and really assessing and checking these things to make sure that if there's any localized pocketing, that you're really warning the patient that there's potentially a crack or a fracture in this tooth. And that's what I did with this lady. I said, I think there's a fracture crack here. And she's like, no, I want to, if you can take the restoration out and have a check, and really I want to be sure. But yeah, this is, as we start to remove the composite that's in there, you can really see it's quite a wide crack in that mesial. That's even without all the full restoration out. And you can sort of just see it drifting up to the distal part of the tooth. And then when I take that final bit out, you can really see that crack running straight along the floor, sort of through the isthmus, and up the back part of the tooth there as well. And so, again, when it's that wide, there's nothing you can do really. You've just got to. There's no false hope there. This tooth needs to be taken out. And then we actually took it out for the lady at that same appointment, because she didn't want to consider implants for the 7. And yeah, you can really sort of see the full extent of how far that crack goes now. It's certainly going down as far as the photo leads, middle third, down towards the apical third. It's quite a significant crack. And again, being able to document and show someone that through a microscope and with a camera attached is really useful. If you do end up having to take these teeth out, show patients, say, look, this is why we can't do it. And they're still grateful and that you've tried. I think that's on the other side of the tooth. You've still got a bit of a sense of the crack there. It's not quite as wide as the mesial side, but the distal side, you can really see the extent of that crack and that split that's going through the tooth. Same again. Failing restoration, doesn't look particularly great. It's not well obturated in the mesials. Got radiolucency. It's just giving us a sign that this hasn't been, treated well enough the first time. But then that's really good for us, because then we can go, right, okay, if I can improve on this, this and this, you can have a really good chance of maintaining, keeping this tooth. I think a lot in the last sort of 10 years, people have been placing implants more because they said, root fillings don't work, retreatments don't work. But sometimes this is, we've got a great chance of this working. You're going to save that patient a lot of time and effort with an implant, and, buy them a lot more time at this point. You can get it, clean it, it's like a pincer, and obturate it, seal it, core, and that's all going to heal. And then we'll get a crown on there. So I won't go too many more of these, because I'm conscious that we're getting up to about the hour, and so there's a little bit on cone beams that I want to kind of get through. These are some ultrasound tips that are great. The dense ply ones again, the top one, because they're not diamond, they tend to last well. The number 4 is for removing posts. Ultrasonics taking posts out are great, inserting something like this where I've got a failing premolar with a post in place, and if I think we took the crown off, again similar to the one I showed at the very start, multiple tooth isolation, some wedges in between there. For me, I just find that works best, so then I can then just do the restorative part and then move straight to retreatment part, and then go straight to temporary and restorative part again, sectioning, taking it off. ultrasonics, removing the post, it's a pretty big chunky post that's in place, and then finding the canal beyond that, obturating it, and then So a little bit about sort of root surgery or apical surgery, microendodontics, whatever people are calling it at the moment. I think actually in the next years we're going to see a lot more of it again, because certainly looking at chatting to some of the guys who I know are doing more and more of it, the success rates you're getting from it are really good, and certainly as to try and delay potentially implants. If you're seeing a tooth that's got a really big post-retained crown and the restorative side of things look good, and it's a toss-up between whether you're going to take all that apart then try and redo it orthograde. If you can again clean and obturate and seal that space in that area, then the apical surgery is certainly something that we should also be considering. So one of the reasons is to say that if you've got a really big post, or you think this tooth's not going to be able to withstand removing the crown, removing the post, redoing it all, then sometimes you do things surgically and you've got the right sort of tips to get 3, 6 or 9 mil up to the post, you can you get a really good chance of survival of these and success in healing. Again, if you find that sometimes you can't actually dry a tooth, I know it's sensitive more upper anteriors, sometimes they've got big lesions and you just can't dry after multiple dressings. Sometimes they're the ones where there's something going on extraradicular outside the canal that you may then need to just move straight to a kind of a surgical approach, and you can obturate it and do the surgery at the same visit, or you pack MTA up to and then back for a GP at a later stage. They're ones that it's certainly worth considering the surgery for. If you can't get to the apex and there's still an area of infection that you've tried for, if you're spending hours and hours just trying to carefully get through and you're just not getting anywhere, sometimes it's better to say, look, if we go in surgically, we're going to get there, clean the apex and seal it up with some MTA biodentine, or some of the Shotlander putties are really good. And again, the other one is, I suppose, cosmetics. If you don't want to be removing loads of nice recent crowns that are done and you think you can manage that area, again, it's just assessing the tooth and seeing where the potential bacteria are and how do we get there and improve on what's there previously. So in this case, this crown was fine. It's got 2 big fire posts in. It's really quite a large lesion, but we're starting to see some areas of apical resorption, external resorption there. So it's quite a large lesion. It hasn't been insufficiently irrigated, but the margins were good. So as patient, we decided actually let's try a surgery. Raised a flap. Sorry, it's a bit gory for an evening if people are eating, but made a pathway through the bone. And so I used micro mirrors, then clean it all out, ultrasonic tips, suture it up, and then place it back over the top. And it doesn't sort of show up too well, but we've got some MTA and back packed up right to where those fibre posts are on that, and then usually the body's just really good at then healing after that, and that was done a few years ago. I don't think I've got that's a few weeks later, we've got all the healing. There's no sign of any swelling or sinus around it, so don't discount sort of apical surgery as a sort of go-to option for quite a number of these cases, especially if the obturations look really good or you've got files in areas that you don't think you can get to. But before considering a surgery, you certainly want to be taking a cone beam. Again, cone beams are going to be, I think, used more and more, again, especially because we can get the field size down to sort of 4x4, 5x5 cones, and we can reduce the parameters, so we've got a high, small on the foxhole that you're going to see a lot for endodontics. And the ESE guidelines recently are really good, and they're, that's in the IEJ, the International Endodontic Journal. They've got some good guidelines on when we shouldn't be using CBCT. But I know one of the guys in London, Shannon Patel's doing a lot of cone beam. Well, a lot of guys are doing, taking cone beams routinely, certainly in retreatments. And I'm doing it more and more now, because every time I take one, I'm always seeing something that I just don't think I would have known had I not taken the scan. So it really is impacting on how I actually approach the treatment and what we're kind of doing with it. So if you've got access to cone beam, it's brilliant. We're seeing these are the IEJ ones, so you can have a read through those on the paper. I won't read it all out to you, but certainly with surgical endodontics, a cone beam is almost a prerequisite to have, I think, nowadays. But if you don't have access to it, then there's still a benefit in doing it. But So in this case, there's a lady who's having on and off buccal tenderness above the upper right one. She's wanting to change the crowns. She didn't like the colour match. So she also wanted to consider changing the crown in the upper left one. And we could see that on a radiograph, certainly something on the upper right one. The obturation in the upper left one doesn't look amazing. It doesn't look terrible, but there's something going on there potentially. So before, I was thinking, well, do we want to try and take posts out, or are we going to do things surgically here, or going to go through orthograde? Are we seeing an element of external resorption? There's something in the upper right one that's all a bit sort of radiolucent. So she's having symptoms the upper right, but not the upper left. This is another image just to see if we can see anything a bit more clearly. You can see certainly in the upper right one, there's definitely something going on in the upper left one, possibly more so now, but it is a bit short. So Vera actually took a cone beam, because it means we can get a lot more information before we actually do anything for these teeth, and it's going to impact, you know, her choice of what treatments that we want to kind of do as well. And we can see there's a huge lesion on the one that we knew, but also a significant lesion on, so in the right and also on the upper left. And we see it in a side view, you can see that it's actually all that buccal bone is gone from that upper right one. There's no buccal bone there, so we're going to have to, you know, hope by doing it, if we do orthograde, that we're going to get a lot of healing of that bone mass. But I think in this area, we've, you know, been able to show the patient a lot more and actually consented to the fact that we're going to attempt to do this, you know, by removing the crowns, which we can do anyway. So therefore, we'll retreat them, you know, orthograde by going through, taking the posts out. But there's a chance that we might still need to do a surgical option, and then that may then affect how I'm going to obturate these teeth through the canal. And if I'm worried that I might need to go in surgically later, I may well do the MTA obturation at that point, so that I know whenever I'm going to go in and resect tooth that I've already got a pack of MTA there, that I might just need to clean out the crypt section off the last part of the root when I've already got an MTA plug right at the base of the tooth there. So this is as we're isolating, removing the old crowns. So the one on the right as it was, but on the left on this image, it's got a post in there. But I think we've removed that just with some ultrasonics. You might be able to see the upper left one we've done without, but the upper right one, this isn't even the fancy ultrasonic tip, this is just a regular one. I've just cleared some space around it, and then once you can get that space with a GP around it, you can kind of move it relatively straightforward, and then it's just a case of getting hold of it or getting it loose enough that you can take it out. But they don't all come out this easy, but it's just having the space around it so that you can actually activate the ultrasonic tip and get it starting to move a little bit. So go at max speed. Yeah, they're going to come out a bit more. So I think it's just the GP that's actually holding this in, but I'm just going to keep it moving. Running it with water, sometimes when it's dry, but you've got to be careful if you're running it dry that you're not overheating everything, because these tips will get red hot if you're not using them with water, and as well as the post, it can then end up heating the dentine, etc. So you don't want to overheat it. So again, using water. Other way is just to occasionally blast a bit of endofrost onto it if you're worried that things are getting too hot. Probably getting irritated that it's not coming out when it's moving this much now. But there we go. So ultrasonic, so yeah, great. And this is a similar one that I showed on Monday night when I was just talking about cone beam generally, and it's a case of a lady who was having vague pain on the lower left side. 2 teeth have been root filled. Both root fillings look relatively, good, within 1 to 2 mil of the apex. Possibly something going on the distal of the lower 6 root. Possibly something on the mesial 7. So this is when the 6 is so heavily filled. The patient doesn't like having treatment, and so the thought of having any treatment is too much for her. So I want to make sure that we are doing something. We're doing the right thing. So for her, I discussed taking a cone beam, so it doesn't involve any drilling, any doing anything. We're going to get a much sort of fuller picture of exactly what's going on. This is where I've just taken a second image just to see if I can see a little bit more, doesn't clear anything up. And then here we've taken a cone beam, and again, if anyone's watching Monday, it's the same patient. You can actually see that it is both the 6 and the 7 that are failing. The 7 on the mesial root, we can see there's a radiolucency, and the 6 actually has completely missed distal root altogether. So this lady decided not to go for any treatment because she didn't like the idea of having to have both teeth treated. She said her symptoms weren't bad enough that she wanted to do anything at this point, and obviously you can sense that things can get worse. But she didn't want to sit through, potentially having to have the mesials or the 7 done, and then the distals or the 6 going through crowns, trying to take crowns off, trying to take posts out. She's just decided that actually now she knows the answer is it's actually both teeth. She's just that, no, that's it. I don't want to do anything. My symptoms are manageable for her, and she'll consider implants in the future if she finds that they get bad enough. I think she's kind of gearing herself up towards that rather than 2 loads of retreatments, restorations and 2 crowns, which is fine. And it, for me, it's better to tell her that at this point rather than getting part of the way through a root filling, a retreatment on 2 teeth that aren't the easiest to retreat in a patient that doesn't want to sit still. It's not going to be fun for anyone. So yeah. And again, this is a cone beam similar sort of case, but this guy decided no, he wants to treat them, and actually again the cone beam shows us that there's lesions on the 6 and the 7, and actually pretty much all roots are involved in some cases. So sometimes you can do partial retreatments if you see one root is the only one that's failing but the rest of them are fine. But here it was the 6 and the 7, everything was sort of associated lesions getting up into and towards and close towards the sinuses. And then that's after it's retreated, and we're starting to see a little bit of resolution of the apical areas. But yeah, I think I've run a little bit over. But yeah, that's just the thing. I always use PTFE because I find it much easier to clean out rather than using cotton wool pellets. It's less messy. But yeah, I'll stop sharing my screen there now. I think there's a few questions that have come through. I think Adil will be there as well in a second.
Hi Tom, still there?
Yeah, that's fine.
Have you got the questions?
Yeah, I think there's one in the chat first I'll do, then I'll go to the Q&A section. So it says, excellent. At what angle should the file be used to explore more mesial canals in lower molars? I'm not sure what you mean. So explore more mesial canals than those. So do you mean like middle mesial canals, or do you mean that if you think there might be 2 canals that are joining? I mean, a lot of angles of files, you just need to be kind of reading the radiographs that you've got first. So you can see that it's got a curvature that's going distally. Then you want to sort of almost pre-curve. Do you know when I say pre-curve file? I see I've got a picture of a pre-curve file as opposed to a pre-bent file, because that sharing again. So this is the sort of difference between a curve and a kink. A kink is very kind of acute and it's bent, and sometimes that's okay just for sort of picking and feeling, but you wouldn't want to kind of get that binding and rotating. Whereas the lower side of it is when you've got as this very slight general curve, you can use endo benders or just very gently just just bend it gently with around a probe or something. But that curve, it allows you to kind of just feel gently where you may find that there's a ledge or a blockage. You're just going to try and if you mark with the little rubber stop on your file which way the curve goes, the rubber stops have like a little indent or a little point mark, so you know on your file where the curve is, and then you can then gradually just carefully pick and feel. A lot of it is done on sort of touch, but you want to just assess the file first. Assess the radiograph first and see which way your curvature is going, and then try and work it that way, and just know where the curvature on your file is by using a little rubber bung to sort of point in that direction. So what warnings do you give as risks of RCT? How do you rate success rates of your RCT? Or Re-RCT. So risks for for any endodontic are always there. I always tell people that it's not 100% guaranteed. It's a host response in respect to bacteria. We're trying to reduce bacteria down so that your body can then heal and maintain it. But I would tend to always warn sort of file separation, perforation, fractures, cracks, hypochlorite injury, the need to have a sort of full coronal restoration afterwards. But for Re-RCT, giving sort of success rates as well, I don't always kind of quote figures because it really depends on why it's failing. And I think that's why sometimes if you can sort of explain to a patient beforehand why it's failing and say it's failing for this, this, and these reasons, I think I can improve on this, this, and this, that's going to give you a good success rate. Whereas if it's that one that had the root fracture or the crack through it, and I can see it's been obturated quite well close to the root apex, that's when I'm going to say, there's no point telling them, oh, root treatment has an 80% success rate. If I'm worried there's a crack there, I'm going to have to say, look, generally, if we can improve on all the things, you're going to have, 80, 85, 90% success rate. But in your case, which is the only one that you care about, there's a big crack there, so that's going to reduce that quite heavily. So I try and steer away from giving percentages because you want to tell people more so in response to their tooth what's going to work. Because again, if you say, oh, it's got a 95% success rate, but it fails, they only care about that. They're in that 5%. They don't care that in 95% of other people it's worked. So you've got to really kind of gear it towards what you're seeing and what you think you can improve on. Well, for me anyway. And if you aren't sure, if you think, I'm not sure if I'm going to be able to improve on here, is it just the fact that I'm going to clean it and irrigate it for longer and better? Then you want to say to them, look, until I start, I don't necessarily know. And there is always going to be a risk in these things. And, say it's going to, the cost is X, Y and Z with a crown, but there's a slim chance that this could fail within a year or two. Are you going to be annoyed that you've spent the time and cost, or are you going to be happy that you've tried it and you've, attempted to avoid an implant, and if it works, great? And so if they say, yeah, no, I definitely want to try this, I don't want to lose a tooth, happy days. But if they say, oh no, I'd be furious if I spent money and it didn't work, then, unless you're really, really super quiet and you're desperate for work, then you don't want to be treating those people because they're not kind of buying into and realizing, I'd much rather, not do a treatment on a person that I didn't think was right. Even, I think it's going to be, a slam dunk. You want to make sure that people actually understand it. And sometimes it just takes a bit of time. Sometimes these people will come once and you'll tell them that and they go, I'm not really sure. And then you'll see them 3 or 4 months later and they're kind of taken on board a bit more. And then they may be more, willing to go at that point. So success rates are, you'll find studies that are quoted in, but I tend to kind of gear it more to what I'm actually seeing and what I think I can do. Benefit of heated sodium hypochlorite, yeah, definitely. That's the higher the concentration, the more time it's in contact, and heat, it just improves all these variables. So if you can heat your sodium hypochlorite, great, it's going to be more effective. The only thing is how you're going to heat it, because if you heat it in a syringe and then syringe it into the tooth, by the time it's gone through a 30 gauge needle, it's warmed up, it's got to tooth temperature, so it's no longer hot. So you need to be able to find a way of heating it in the tooth, and to do that safely. So one way is to use a dry ultrasonic, like an irrisafe tip or something, and agitate it. That will add a little bit of heat. Or the other way, if you're using warm vertical, if you've got like the warm vertical down pluggers, and you've got to find one of those, then you can, and as long as it's not touching the walls, you can place that in the irrigant and then start to heat it 150, 200, or whatever it goes to. Then you can use that to try and warm the irrigant a little bit. But trying to heat it before and get it from your syringe into the tooth, I don't think it actually warms things up too much. What irrigant is best for sclerosed canals? So sodium hypochlorite is good in some cases to actually see where the sclerosed canal is, because if you've got good magnification, you can see, and the sodium hypochlorite will bubble a little bit where it shows you where, if it's active and it's killing bacteria. So sometimes sodium hypochlorite is good, so you can just sort of show you potentially where the canal is. But the other one that's good to help with treating it is liquid EDTA. So it's the same thing that's in Glide, because that removes a bit more sort of inorganic material, so the dentine smear layer, etc. So sometimes I use a liquid EDTA, but you've got to make sure you're drying in between your irrigants. If you use sodium hypochlorite first, make sure you're drying it really well with some paper points, and then you can use EDTA after that. So that, would be the one that I would use. What is the best irrigant to remove GP? Saying best best, if you want to say, is none. You want to try and take it out without a solvent, because if you can get it out whole, then you're not creating this kind of GP irrigant sludge. But if you can get it, the best thing to remove GP is chloroform. It's a controlled liquid in the UK. I've got some from an old endodontist, Jeff Seckham, who kindly gave me about 10 litres of the stuff. But you can get it if you from some suppliers. I'm not sure where, so I've got big jars of the stuff. But I know other people use eucalyptus oil or some sort of orange solvents, that one as well. But chloroform, if you can get it, it's great. Risk of tooth splitting following RCT. Again, it depends on the restorative factors. So really, if it's a patient that's a bruxist, or they've got really strong masters, if they're clenching a lot, if they've got signs of wear facets on all their other teeth, and they come in and the masters are out here, then yeah, they're going to have a high chance of splitting it. Or if it's a little old 80-year-old lady who's the tooth unopposed, it's got nothing against it, or it's adjacent to a denture, then you're going to have a less chance, and also the size of the restoration that's in it. So, molars, premolars, if you're worried at all, certainly you want to discuss the benefits of crowning or placing an onlay on these teeth. But it's a case-by-case thing. You just need to kind of assess your restorative indicators that are there. That kind of leads on to the next one, indication for indirect cuspal coverage. And I would certainly tell most molars, for most people would have, I tend to do onlays as opposed to full crowns, but obviously depends what's there. But if you've got any thin walls, thin cusps, you need to get something on there. Sometimes if I'm really worried a tooth's going to crack or fracture, if it's got very thin walls, I'll just, when I obturate and place a core, I'll just reduce the cusp heights and then just overlay a direct composite, or sometimes even prep it for a temporary crown and put something on there if I definitely don't want the risk that that's going to crack or split. What cases would I recommend a CBCT? I would read the IEJ ESC guidelines because they're great. Certainly the ones I'd say for me is a must-have. Anything surgical, so I was going to do any apical surgeries, I would want a CBCT. Retreatments in molars, a lot of the time I'd want a CBCT, because you can see it a lot more. Certainly if you can't see why it's potentially failing, the obturation otherwise looks good. Any kind of concern of internal external resorption, for me again CBCT is very useful. Orthograde stuff, routine stuff, I don't take it regularly, but yeah, I think the uses for cone beam are going to get more and more in the next few years, especially because the dosage is coming down so much as well. But yeah, read any of Shannon Patel's papers on cone beam and the guys at King's, because they're all pretty clear on how they're using it, and this is certainly going to be used more and more, I think. Is there any problem with extruded root canal sealer beyond the root apex? Yeah, you want to avoid it. You don't want to be piling loads of sealer out there. And again, it depends on the type of sealer that you're using. If it's a biocompatible one, if it's a bioceramic, then it's probably less much of a concern, but it's going to create a tissue reaction. AH Plus is quite runny and will go out there. It's resin based. Anecdotally, and papers will say that it's not always a big issue, and things can still heal around it. But it depends on what you're kind of extruding into. I personally don't aim to get sealer puffs on my radiographs or with my shaping. It sometimes happens, again, especially if you're using quite something like AH Plus, which will so be a bit more runny compared to things like Cheetah Seal, but you wouldn't want to aim for it. And then again, it's the quantity. If there's loads of it out there, and then the thing's not healing, then that's when you're probably going to have to think about the surgical option. Thanks for a good presentation. If there's a file separation midway down the canal and you manage to get past it, do you then continue the debriding with only hand files, or would use of a motor for a tip afterwards increase the chance of a second file separation when in contact with the first fracture file? Yeah, no, great question. Some of that comes down to sort of touch and feel. If you think you can create a good glide path around it with hand files, sometimes the reciprocating files are okay to use. because they kind of go in and then out. Sometimes that'll pull the file out a little bit more with it. Rotary ones, you've got to be a little bit careful at what part of the file it's binding on. So if I was going to do that, I'd want to make sure that it felt like a rotary file was. So if you say you've bypassed it and you get past it with hand files, you kind of want to make sure the rotary file you think is going to be able to get past the file as well. So it's not just kind of starting to bypass it and then catching, because that's when it's got a chance it can kind of get caught. So you probably would want to use hand files a lot more and really create a glide path beyond the file. But then I definitely do use rotary reciprocating files to then try and shape the rest of that canal afterwards. But you just have to be very aware of the fact there's a file there, and just use it in a brushing motion carefully first. Don't try and overuse it. You're trying to sort of kind of work away from that file. You don't want to try and get anything that's going to engage into it. So you just got to be a little careful, a little mindful of it, and maybe use something with a finer taper first and just go through more sort of file sequences. Deputy says, what is worse, short obturation or over obturation? I mean, see, ideal obturation is best, but what is worse? Okay, I'll split it up. If it's a necrotic tooth and there's a big periapical radiolucency, so there's a lot of bacteria down there, a short obturation, I suppose, if it's a short obturation but you've irrigated to the end of the tooth, it's possibly not too much of a worry, not ideal. But if it's a short obturation because you haven't irrigated and cleaned at the end of the tooth, and it's a necrotic tooth where there's lots of bacteria, then that's obviously going to be worse than if it was a necrotic tooth and you've over-prepared, but you've cleaned everything and you've obturated a little bit beyond. If it's a tooth with irreversible pulpitis and there's not actually that many bacteria down there anyway, most of the bacteria are going to have been in the coronal part, then a short obturation is probably you're going to get away with, because actually there might not be that many bacteria down there initially anyway. But an over obturation is sometimes a sign that you've obliterated the end of the tooth and you don't have that kind of apical constriction anymore, and so you've lost a bit of control. But again, it depends on what's happening around the outside of the tooth and the actual bacterial status of the canal beforehand. Say if it's something that's had just irreversible pulpitis and the bacteria only really in that top part of the coronal part, then there might not be that many bacteria down there anyway. So short or long's not bad. But if it's necrotic, it's been dead for a while, you've got to be a bit more, assured that you've cleaned things well. If you have a subgingival margin that you can just about isolate and build up in composite and then complete the root filling, would you crown it, assuming it needs one, as this would be difficult to record and the imp take it? I mean, a very specific case, but I mean, yeah, definitely. If you can isolate it to place a major expander, know that you've sealed it, even if you've sealed it and you've placed amalgam, I would then either consider crown lengthening to be able to place an extra coronal restoration, or do something with like a vertical margin. So you're using zirconia, PFM metal, but you're not trying to create a big chamfer or a shoulder. You just really, I'm sure you guys might know the vertical preparation technique, you're just trying to take it into that sort of area of connective tissue with a seamless knife edge margin, vertical margin, and then your technician then will need to build it out. But you then need to be able to use retraction cord and PTFE tape, etc., to be able to capture it on your impression. If you really didn't think that you could do that, and you were super confident that your matrix was sealed, and you used composite, well, then that's deep margin elevation that people talk about. So if you're really super happy that you've restored it and the composite's bonded really well, then you could just leave your onlay crown margin above that and have a deeper margin of composite, or you could do a deep margin elevation in amalgam if you weren't sure either, and then just leave a metal restoration on an amalgam margin if you feel that you're going to then get a better extra coronal restoration. But I wouldn't, if it's that heavily restored already, unless you're really just buying this person a year, I wouldn't say, don't put a crown on it. It's a tricky one, because sometimes you feel a bit invested and you think, oh, I want the patient to pay again, and more of it's already a bit suspect. But that's the consent process. That's what you've got to tell them. You've got to say, look, it was me, cost involved, would be doing the crown on this tooth. And if they decline it, then, and patient declined due to cost or didn't wish to do it, patient accepts the risks. Would you monitor asymptomatic under or over obturated teeth? If yes, then how long for? Is this one that you've just done, or one that you've seen, you've said patients come in and you think, oh, this needs a restoration, and then you take a radiograph? If it's under or over obturated but it's asymptomatic, I would take a second image. If it's one that someone else has done but you see there's a lesion there, then I probably wouldn't monitor. I'd say, look, this isn't ideal. But again, if patient consent, if they say, oh, I don't want to do anything, that's fine. But if it's one that you've done and you think you've under obturated or you've over obturated it, then yeah, you could monitor it for 3 to 6 months. I wouldn't. Again, you've got that risk that if the tooth then fractures and cracks, then you've just been monitoring it as it's broken. So again, you may want to put a temporary crown on it, just chairside temporary, or you may want to just reduce the cusps, do a direct composite overlay, just so you've got 1 to 2 millimeters of composite covering over the top of it, so you've got some protection, or an orthoban or something. So if you're monitoring it because you want to see how it responds, you've got to provide some sort of protection, or certainly consent the patient that they've got to be careful, and if they break and crack it, then that's the risk by leaving it. But again, it comes back to why it's under or over obturated, and if you feel you've cleaned it and you've done everything really well, and it's been pulpited prior to that and there's not many bacteria, that's a very different story to one that's had it's got a huge swelling lesion, and there's been a really big radiolucency. Then yeah, you may, and you think that it's not quite been obturated as well as I want to do, then yeah, you probably would want to monitor it for a period of time. But I would try and do some sort of protection with a direct overlay or a temporary crown. Ultrasonic tips used for post removal is the same as the scaling ultrasonics. In that video it was, just because that's the one that I had on there, and it was quite loose anyway. But you can get special ultrasonic tips for post removal. They've usually got like a little kind of sort of wider ball at the base of it. It was that one that was in the picture, just because it transmits the ultrasonic waves slightly differently. So yeah, you can get special ones, but it really depends on the type of post that you're trying to get out. If it's a straightforward loose one, a normal tip might work. But if it's a big, thick, heavy cast post, you might need to use a slightly different one. But you can't always rush to take posts out. You've got to be a little bit careful, because you don't want to end up. A tooth that's got a big post in it has probably got a big post in it because it's already quite a heavily restored tooth. So you don't want to put loads of energy through it and end up fracturing the tooth or doing anything more. When a white spot is seen at the orifice of calcified canal, how do we then access it? Good question again. A lot of the time it's time and patience. So you just need to take care and time. The end cutting C+ files, hand files, they're quite good because they're slightly active at the tip, but maybe a little bit of EDTA or glide, and then you just have to carefully just pick a little bit, rinse it out, check again, pick, or you have to use something like your ultrasonic or your gooseneck burr and just slowly take it away. You won't always be able to get, if it's calcified for a long distance, or you'll see it, you won't be able to get through it with your file. You'll just need to use something like gooseneck, a very fine gooseneck burr, and just take another little bit away, try it, check it, see is that calcified spot still there. If it's still in the middle of what you're drilling, it's fine, go a little bit more, clean that spot's still there, but you can't get it with a file, then just drill a little bit more, and it's just a slow process. But yeah, as long as you can keep seeing that dot and it's in the middle, to keep checking, is it in the middle of the root, is it in the middle of where I'm doing it, my angulation's right, and just gradually going through it. Can we retreat roots filled with bioceramics? That was the worry, that if you filled something with bioceramic like MTA and it's absolutely rock solid, that you're not going to be able to retreat it. And some of them probably are absolutely rock solid. A lot of the ones that come, you'll have like GP and a bioceramic sealer. To the GP, you can get out, but it certainly is. It's potentially going to be more difficult. But yeah, I haven't had to retreat many of them, and I wouldn't fancy taking out, you know, a huge, thick, big bit of MTA. So, I think what they say about some of the newer bioceramic sealers is that you can retreat with them. They're not like a block of concrete that you can't get out, but you probably just need to be able to see and carefully use more sort of headstrong files, etc. Solvent's not going to do anything to it, so you're basically going to have to use files and probes to get it off. What instruments do you use to retreat teeth or trade? Oh, same question, yeah, with MTA or bioceramics. Yeah, it's probably trying to get the GP out and then just having to use sort of stiffer files, but thankfully I haven't had to do many. When one canal is missed, do we retreat all canals or just that one canal? Again, a good question. It really depends on how the other canals look. If they all look absolutely perfect, and say it's a referring dentist that you know does very good work, and they've said, oh look, I can find 3 of these canals, I can't for the life of me find this 4th one, I've sealed the other 3, can you just do the 4th one? Then if you have trust in that person and you're happy, then you can just do that one canal. But it all comes down to your level of control that you want to have over a case. So if it's been retreated donkeys years ago, but one's been missed, I'll often retreat them all, because I think, well, actually, from a time point of view, I can do them all. Now, I don't want to retreat one, find out it doesn't settle, and have to go back and do the other one. But if the other ones look like they've been, you know, they're going to be really difficult to retreat, and there's just a lesion on one, then I might just do the one missed canal. But leaning back to it again, that's where things like cone beam are probably going to be really invaluable, because if you can take a cone beam, say of an upper 6, and it shows that there's no apical pathology on the distal, no apical pathology on the plate on a cone beam, which has got high sensitivity and specificity saying, yes, if there's disease, we can see it, but there is on the mesiobuccal, then that's possibly when I go, actually, I'll just do the mesiobuccals and we can leave the other ones, because the cone beam has got really high sensitivity for saying if there's disease, we can see it. Then I'd consider that. So again, a cone beam will prove really useful in the case of a retreatment or a missed canal, that if it shows you, conclusively that you're happy that there's nothing else there, then that's quite a good one. Please share some tips on exploration of canal orifices in upper molars. I would say there's, let me see if I can find it again. There's a good paper that that's got the anatomical laws of what you're looking for. Sorry, this is a different lecture, but so the paper that goes to the anatomy of the pulp floor, so the anatomy of the pulp floor by Krasner Rankout, that one's the best thing. They've got some just black and white schematics that sort of explain where you should be looking for and finding canals. With the law being, as I said earlier, it's always in the centre of the tooth. The law of centrality says that the pulp floor is always located in the centre of the tooth at the level of the CEJ. The walls of pulp will always be concentric to the external surface, so there'll always be that same distance. And that's all related to the CEJ, where that is. And then again, these are some of the, as I mentioned there, where you've got this midline through a lower molar, and as you asked about upper molar, but not lower molar, if you've got a mesial and mesiobuccal and mesiolingual, they'll always be equidistant. So if you can find one, and you know where the midline is tooth, then you know the other one. So say you find the mesiolingual, you know the mesiobuccal is going to be the same distance from that. It's not going to be, miles out. In the majority of cases, there's odd anomalies, but this is generally the case. The pulp floor is always going to be darker in colour, and I say there's always a distinct junction where the floor and the walls meet, and that's when you'll see that sort of change in colour. The orifice is always going to be at the junction between where the floor and the wall meet. Let's see if I've got that picture again. So you can see the floor looks a bit sort of grey and darker, where the walls are a little bit whiter, and where they're sort of in the corners where the floor and the wall meet, it's always going to be where you're going to find the canal orifice. That's when you know you need to look. See, MB2s is slightly different, but generally for the main canals, that's where you should be looking. But I'd say that, I'll get it back up so people can, Krasner and Ranko, that's the paper you want to look at, because that's got a lot of these sort of black and white schematics that can kind of show you and explain a little bit more about where these things are. Again, if you've got lower molars with 2 roots on the distal, you'll see a little bit more there. That's where you can really see that kind of colour change from the floor to the walls, and even more so when it's dry. Sometimes actually wet in the pulp, you can see things a bit more. You get this angle of reflection through liquid and water. It can show things a little bit more easily. Just videos that'll sort of show things a little bit. But yeah, I'd say that paper is probably the best thing you could look at. Do I promote intentional extraction and reimplantation of the same tooth after treatment endodontically outside the oral cavity? So do you mean in the, like, if it's a decoronated sort of anterior, or in the tooth? I'd only do it. The only case I would do it is if you really wanted to get some, say, the more feral to restore. So, say it was a bilateral that had decoronated, and there wasn't enough feral, or I would say, okay, that's got a really long root, then yes, you could sort of try and extract it, or use the Benex extractor where it like bolts the thing out the mouth. Then you can try and re-implant it, but slightly twisted so it's wedged up a little bit. It's meant to work quite well. Ortho extrusion is probably a neater way of doing it though. So use orthodontics. So root fill it, and then put comms or whatever on there, and then actually put a bracket on it, and then try and sort of ortho extrude it that way. But then I suppose it's how you can isolate it to do the root filling. Yeah, you'd have to. That's pretty much a case by case. But I wouldn't do it routinely. I know some people do reimplantation from other areas of the mouth into an area potentially, but yeah, no, I think you'd have to find a very simple case. It'd be cool to see though. It'd be good. I mean, there must be some papers on it, but I wouldn't. For a retreatment, it would probably be quite tricky because you wouldn't have time to retreat it out of the mouth. But for a original root treatment, you might be okay. But yeah, so I know I've got about half an hour of questions there. I'm sure everyone probably wants to get on with it.
Thanks very much for that, Tom. Appreciate it. I think that's all the questions. I think we should stop there as well.
Yeah.
But thank you very much for today. It's much appreciated.
No worries.
I'll let you get off and get some rest.
Cheers, Ben. Thanks a lot. Thanks for everyone for attending. That's great. Any questions afterwards, just, I guess, email these guys and let them know.
Well, take care.
Cheers now.
Bye-bye.